We are continuing with the next speaker, which is Pinar Keskinocak. Pinar, I hope you're online and you can hear me.
I'm here.
Hi, Pinar. So what to say about Pinar? So first, Pinar is, first of all, right now, the president of Informs, which is one of the biggest operations research societies in the world. It's the US society, but de facto, I guess, the most influential one in the world. Pinar is currently its president. She has been at Georgia Tech for over 20 years, where she is a professor in the School of Industrial and Systems Engineering. She currently works on health and humanitarian systems. She's the co-founder of a center for the Health and Humanitarian Systems Department. I know, actually, I have the pleasure of having interacted with Pinar personally. She convinced me 15 years ago to come to Georgia Tech, and we were colleagues. And so it's very nice to see you. And back then, I remember, actually, when I went back to the Netherlands, I was reading, sorry, some turbulence. I was reading a very nice survey on dynamic pricing, which was one of your earlier research topics that you worked on. But the last couple of years, you've mainly worked on public policy. And of course, especially the last 18 months, you have been very active in public policy for pandemic response. And so, yeah, I'm looking really forward to your talk, which is, I guess, related to this topic.
Thank you so much, Bert. It's a great pleasure to be here. I'm going to try to share my screen. Give me 1 second. Hopefully it works. Okay, please tell me what you see.
I see a title slide.
Do you see two at the same time, or?
And now we also see you.
Is this better?
The next slide and you. Now I just see the current slide and you.
Okay, this is better.
This is good, yeah.
Okay, I'll keep it this way. It's always a challenge, you know, with the technology. So thanks again for having me here. It's truly an honor and pleasure to be here with you. And Bert, it's good to see you, quote unquote, even though we are on two different sides of the Atlantic Ocean. My research team here is comprised of a number of faculty members and students from Georgia Tech, and I also collaborate with several colleagues from other partner organizations. So let me express my gratitude to all of them, as well as all the companies, foundations, and Georgia Tech alumni who supported our research over the years. So Bert, I'm gonna continue if that's okay. Can you all hear me okay?
Yeah, do continue.
Okay, perfect. And I'm gonna see if I can manage to see the chat here.
I'm going to moderate the chat for you, so people can ask questions in the chat, and we'll treat the questions in the end.
Yes, please put things in the chat, and if it fits with the flow, I will try to address it as I go forward. And I guess I'm the only person standing between you and the reception, so hopefully we'll finish this on time. Okay, so this presentation is going to focus on modeling specifically related to infectious diseases, but our team's research spans a number of other areas of health systems, including non-infectious diseases, and also on the humanitarian side, disaster preparedness, response, and recovery. So I would like to invite all of you to visit our website of the Center for Health and Humanitarian Systems, where you can learn a little bit more about some of our research, applying analytics and quantitative methods in the public sector broadly. So we have had a lot of advances in science and medicine, and these helped us better understand, prevent, and also treat infectious diseases. But despite our progress, infectious diseases still continue to affect millions of people around the world. Some of these diseases, as you know, have been around for a long time. Some are newly emerging, and they cause outbreaks, epidemics, pandemics. So we still have a long way to go in our fight with them. And typically we follow a multi-pronged approach in our battle, starting first and foremost with prevention whenever possible. And when that's not possible, we try to do early detection, which is supported by surveillance, and it enables us to be proactive with our interventions. But sometimes people get infected despite our best efforts and may experience severe outcomes. So that's why it's also important for us to have treatment which is supported by a variety of healthcare resources. So these resources are often quite limited, whether we are talking about people, equipment, other kinds of supply, medicine, and the decisions about resource allocation and usage, how much should we send, where, when, and so on. These kinds of decisions have significant consequences on societies and on human life. So in traditional supply chain management, Bart mentioned earlier that I've done quite a bit of work in supply chain management. We often assume that demand is endogenous. We have some known distribution about the demand, and then we do some calculations and plans accordingly. But the demand for healthcare resources during an outbreak or a pandemic, they don't follow such well-known patterns. And more importantly, there is a lot of endogeneity, how we do resource allocation, the types of interventions we implement, the level of compliance with these interventions. All of these impact the disease spread, and consequently, they impact the future demand for resources and our future decisions. So it's a little bit related to the first talk in the program, where we do learn, and what we do actually impacts what we see in the future. Well, there's a lot of feedback loop between our decisions regarding interventions or resource allocation and the disease dynamics. So the disease models can help us understand these dynamics. They can inform our decision making in multiple ways. So depending on the model type, they can project the disease spread short-term or long-term, providing information at various levels of geographic or demographic detail. They help us evaluate the impact of interventions, not just as standalone interventions one at a time, but also in combination, because often we have to deploy multiple interventions simultaneously or in sequence, and also considering various implementation details, compliance from the public, and so on. The models can be used to forecast demand for critical resources such as personal protective equipment, hospital beds, ICU beds, and other kinds of resources. And then they can, of course, support our decisions about the procurement and allocation of critical resources, such as vaccines. And all of this helps us reduce waste and maximize the public health benefits, while also considering fairness, equity, and some other important considerations in public health. So at the bottom of this slide, I listed a sample list of infectious diseases studied by our research team, and I'm going to briefly discuss the modeling approaches and the underlying dynamics in some of them. So just as a recap, Biology 101, infectious diseases can be caused by bacteria, viruses, fungi, or parasites, and the models typically capture two types of dynamics. So the first one is the natural history of the disease, which refers to the progression of a disease in an individual over time, typically in the absence of treatment. And this often depends on the individual's age and health condition. So the model also captures, those. And then the second piece is that the model captures the dynamics of the disease spread across the population. So that's the second box that you see there. So let me give an example for these two pieces from COVID-19. And a similar representation that I'm showing here would also apply to other respiratory illnesses. So here we are seeing a simple model of a natural history. An individual who is susceptible to the disease becomes exposed and to an infected person, and then after that they go through typically a pre-symptomatic phase, and from there they might become symptomatic or remain asymptomatic. This is hopefully followed by recovery. In some cases, the person's condition might worsen, they might be hospitalized or even die. So which of these paths a person follows and the duration of each of these disease states would depend on the body response, which is of course impacted by age, underlying health conditions, and so on. So we could consider a simpler version of this model. For example, we could combine some of these states together. In an SEIR model, these infected and recovered states are combined and they do not capture some of these other details such as symptomatic, asymptomatic. In some cases, we could have even a simpler model, SIR model, that includes only 3 states: susceptible, infected, and recovered. So what level of detail is appropriate in a model? It depends on the question we are trying to answer, or the decisions that we are trying to support. And of course, it also depends on the availability of the data that we would need to populate these models. If we have severe data limitations, we might not have too much option to create a very detailed model, because then we cannot really calibrate or validate it. So all of these would play a role in our modeling choice. Okay, so that was the first piece of our disease model, first important piece. Now the second important piece is the transmission. So the transmission can be direct. So for example, direct contact between individuals, or it could be transmission via droplets. So that's the direct contact. Or the transmission could be indirect, where there could be some reservoir that contributes for the transmission to the host. There could be vehicles such as food or water that can play a role. And vectors such as mosquitoes and ticks can also play a role. So there are various forms of transmission. So in the models, we try to capture the dynamics of the transmission depending on the disease type. So here again, I'm giving an example from respiratory illnesses such as COVID, where social networks and interactions impact the transmission rate. So we can represent such networks in the models. For example, if we build an agent-based model where there is an agent representing each person, people who live in the same household would be more likely to pass the disease to each other, say compared to people who interact in workplaces or community, such as grocery stores, churches, and so on. And then we could capture all of these different groups, social groups, in our agent-based model, and then adjust the transmission rate accordingly. So basically the frequency, the duration, and the proximity of these interactions between people impact the transmission. And as you can imagine, the chance of transmission is higher the more frequent, the longer, and the closer the interactions are. So you would be more likely to pass the disease, say, in a household compared to a community level interaction. So as I mentioned earlier, vectors play a role in the spread of some diseases, such as malaria or Guinea worm disease. So malaria is caused by a parasite, which is transmitted to humans via infected mosquitoes, and then back to mosquitoes by infected humans when the mosquitoes bite. So there's no direct human-to-human transmission. So because of this, the transmission dynamics are more complex. And for modeling the spread of such diseases, we typically create separate network models for the human population, let's say for the mosquito population, as in the malaria example. And then each of those population dynamics are captured, and then we also link these separate network models together, so we get the big pictures about the entire disease spread. So I gave an example here from malaria, and as you will see here, I listed a small subset of the types of parameters and input you would need for creating some of these models. So in disease transmission, of course, the environment also plays a role, and I'm using the word environment in the broadest sense here. So for example, the climate would impact the mosquito population in case of malaria. In certain parts of the world, transmission occurs all year round. In other areas, the start time and the duration would really depend on the climate and the geography in that area, like how the water sources and their size and so on. So then when we think about controlling the disease spread, it's not only what we do for the humans, but also what we do on the environment. For example, we might use insecticide-treated mosquito nets, indoor residual spraying, or we could treat the water. So all of these would also impact the disease transmission. And then if you think about the big picture, the resources that we have, so we need to consider the disease dynamics, seasonality, and the interaction between these different types of options, depending on the location, to reduce the number of infections. So another example is Guinea worm disease. This is caused when humans drink water, say from a pond that contains water fleas or copepods that have ingested the Guinea worm larvae. So this is a pretty complex, transmission. The copepods, once ingested by a human through water, die, and then they release the larvae into the stomach and the intestinal wall. And then these larvae move to the tissues of the abdomen where they mate. And the disease is a pretty long cycle. It could be 10 to 14 months. So this pregnant female worm grows to, pretty large size, 2 to 3 feet or 60 to 100 centimeters in length. And then when it's time to release the larvae, typically move down, say to the legs, and emergence from legs and feet. This is very painful. If it's a human that's infected, if it's a dog that's infected, it's pretty painful. So whether it's human or dog, they typically seek some relief from pain by going to water, and then this is when the larvae are often released back into the water in this fashion. So then we kind of go back to the beginning of the cycle. If these emerging larvae are swallowed by copepods, which are then swallowed by humans via water. So you can kind of see how complex some of these patterns might get. And in terms of Guinea worm, we've made tremendous progress in the reduction of Guinea worm infections in humans over the years. So up until a few years ago, it looked like we were almost there with eradication. But then the situation changed in some countries. So for example, let's look at the case of Chad, where we did not have any human cases reported for several years, but then increasingly the disease started to spread among dogs. And the way dogs are used in some of these countries, it's not just as pets, but they actually are an integral part, in farming or other activities, other daily activities, and they are outside. So, and dogs and humans frequently may share the water sources, the ponds or other sources that are nearby. So having the infections in dogs clearly poses a threat for human health as well. It's not just limited to the animals. So in collaboration with the Carter Center, which is a non-profit organization which has done a tremendous amount of work in the space of Guinea worm eradication over the years, we have done some work on Guinea worm disease modeling. So like I mentioned, while the number of human cases went down, there's been an increasing number of Guinea worm infections in dogs. So we developed a detailed simulation model to capture the dynamics of this transmission. We considered the Guinea worm life cycle, as I just explained, the seasonality, and also some of the interventions that have been in place. So in calibrating the model, we looked at the joint impact of both temperature and rainfall, and we estimated how this combination might impact the likelihood of transmission, say when a dog drinks water from the source. We also use this model to evaluate the combination of interventions, including abate treatment of water and tethering of dogs. So like I explained before, so if we can actually provide clean water to everybody, this problem would for the most part go away, everybody including dogs. And also tethering of dogs helps because then they are less likely to seek a water source when the larvae, when the worm and the larvae are released. So these are two important interventions that have been implemented, but of course at a limited scale. So our results suggest that if these interventions continue at the levels similar to what we have seen in the past, eradication is unlikely. So we would need higher levels of abate treatment, which is typically more effective compared to high levels of tethering. Okay, so some of the, so just let me just quickly do recap. So we talked about some diseases that are transmitted by direct contact, such as COVID-19. We talked about indirect transmission via vectors, as in the case of malaria or Guinea worm. And now let me talk a little bit about indirect transmissions that can happen via vehicles, such as food, water, blood, or objects. And as an example of such diseases, I'll briefly discuss cholera and the work that we have done in that space. Waterborne diseases such as cholera are caused by very small organisms like viruses and bacteria that are ingested through contaminated water or by coming in contact with feces. And the prevalence of these diseases is higher in areas where we have limited water sanitation hygiene infrastructure. Cholera has caused several pandemics and many outbreaks around the world, and it is endemic in some areas, as you can see on the maps here, some of these endemic areas, especially in Africa. The impact of cholera varies geographically and by age group. So for example, as I mentioned, the prevalence is highest in Africa, and it's also highest among younger children, regardless of location, because of the way children behave and also their immune system. The disease prevalence or risk might also vary even within a country or a smaller sub-regional level, depending on the infrastructure, demographic differences, and so on. And here I'm showing one example where you can see the placement of roads, water bodies, and the risk varying from location to location within one country. So when we make resource allocation decisions for disease prevention and control, these regional or sub-regional differences, demographic differences, environmental factors, we need to incorporate all of these into account along with the disease characteristic. So in one stream of our work, we collaborated with the Task Force for Global Health. This is a major nonprofit organization, and we focused on the allocation of oral cholera vaccine geographically and over time. The vaccine is effective for about 5 years, but it's not going to protect you forever. So the protection also slowly decreases over time. So our model took this into account, as well as the change in population demographics, such as children growing and moving from one age group to another. So we compared our model results to two intuitive and commonly used allocation policies in practice. The age-only policy prioritizes the younger children since they are at higher risk, and the region-only policy prioritizes regions that are at high risk. So we created an optimization model which combines both age and region and some of these dynamics that I mentioned, and it can actually do significantly better in terms of reducing the number of deaths or infections, regardless of which objective we choose. So the differences when you look on screen between these lines seem small, but if you look closer, the number of infections we could prevent by using an optimization approach could actually be in the hundreds of thousands. So the impact could really be significant here. So in this work, we also participated in the development of a comprehensive integrated strategy for cholera prevention and control. This is a large report which became kind of like a reference for activities in this area, and specifically focusing on some of these logistics and resource allocation aspects. So this is another way of expanding our research impact by collaborating with people in practice. I hope these examples give a high-level idea about the different types of diseases, the different types of models, whether it's SEIR type models, agent-based models, optimization models that you might develop and use, and the different types of data that we might need for understanding the disease spread and also informing the decisions, particularly about resource allocation. So in the remainder of my presentation, I want to talk a little bit about interventions, and I'm going to focus mostly on COVID. So the interventions can be pharmaceutical, such as vaccines or antivirals, or indoor residual spraying, as I mentioned, for malaria. Or they can be non-pharmaceutical, such as physical distancing or boiling water. So among pharmaceutical interventions, vaccines, of course, prevent the disease to some degree. It depends on the efficacy of the vaccine. Antivirals can reduce the complications, but they can also reduce the transmission rate. So for disease such as malaria, some of these interventions are on the environment or physical spaces, as I mentioned before. So how we incorporate these interventions into models, it depends on the model type. So for example, in an agent-based model, let's say we have a shelter-in-place intervention that we have seen during COVID. We can implement this intervention explicitly by, say, removing school, workplace, or community connections in the network. So we directly model it. We don't have to make assumptions about how much is this intervention going to reduce the transmission rate. But in an SIR or SEIR model, the interventions are often modeled implicitly by estimating the impact on the transmission rate. So there's kind of a major difference between the agent-based and SIR or SEIR-based models. And the agent-based models could sometimes also inform the input for some of these simpler models. So I listed a number of non-pharmaceutical interventions here, mostly relevant for COVID, but of course you can think of interventions for other diseases as well, especially with thinking about some of the ones that we discussed earlier in the presentations. Some of these interventions are most effective only when they are used in combination. For example, we may have a high testing rate, say in COVID, but it's not going to help us in controlling the disease spread unless it's combined with some isolation or quarantine with some other type of intervention that would actually reduce the transmission once somebody is tested positive. So we actually have done some work in that space related to COVID, and I'm happy to share offline, specifically looking at the interactions between compliance rate and so on. So we discussed the behaviors and compliance a little bit. The effectiveness of some of these interventions depend very, very strongly on the compliance levels. This is also where, learning, education, and so on play an important role. The compliance levels might vary geographically and over time, so they are not necessarily constant. So that's why we need to continuously update our parameters as we run these models. And they can also vary significantly across subpopulations. So these types of compliance with interventions can be, again, explicitly modeled in agent-based models, but not that straightforward in SEIR models. We need to make certain assumptions. And finally, we need disease models combined with resource allocation optimization models to identify the best use of limited resources across various interventions. So this has been a focus area for our research team. So in terms of metrics, how do we evaluate the outcomes? There are a couple that are commonly used in the literature. So for example, new infections per time period, whether it's daily or weekly. We may be interested in the peak or peaks. Sometimes there are multiple peaks. This is when the number of infections, say on a daily or weekly basis, reach a certain level. And when we reach these peaks, that's when we expect the largest stress on, say, healthcare resources or the society. The total the percentage of population infected is also of interest because it gives an idea about the overall burden of the disease in the population. So I might use the term infection attack rate, for example, a little bit later in the presentation to refer to the percentage of the population infected. So I'm gonna pause here for a moment. Bert, could you remind me how much more time I have just to make sure I pace myself in the remainder?
20 minutes including, 15 minutes including questions. So
okay, perfect. We are doing good. And again, I encourage all of you to write questions in chat if you have any questions or comments. What I'm gonna do next is talk a little bit about COVID. We are almost at the end of 2021, but COVID is unfortunately still with us. So our research team has several streams of modeling work in this area, and I'm going to give you a quick glimpse into some of them. So earlier in the pandemic, we developed a fairly detailed agent-based simulation model to project the spread of the disease geographically and over time. And we also incorporated some intervention strategies into this model. So for example, in the state of Georgia, I'm giving a little timeline here. We had school closures earlier in the pandemic. These were followed by shelter in place. And then we had mask recommendations that came a little bit later. In the meantime, the public was, of course, encouraged to follow physical distancing, including voluntary quarantine, where before testing became available, basically we said, okay, so if somebody in a household is experiencing some COVID-like symptoms, then everybody in that household should temporarily refrain themselves from interactions. That's what we call voluntary quarantine, because it's possible that a person may not show any symptoms, but because they live in the same household with somebody who does have symptoms, they might still have COVID and pass it to other people. So of course, later when we have widespread testing available, that kicked in, but earlier in the pandemic, this was very important to keep the disease in check. So to model the network effects and the compliance with these interventions, we also utilize detailed demographic data at the household level and also workflow data, for example, to model the movement between different regional areas, and also cell phone data, which gives us some insight about the movements, again, between different parts geographically. So our early results highlighted a couple different things. About the interventions and the compliance. So for example, we observed that shelter in place puts a big brake on the spread, and it can push the peak further, but it does not necessarily have a significant impact on the overall magnitude of the peak or the infection attack rate. So essentially, it buys us some time, but beyond that, the impact is limited in terms of disease spread. But you can imagine the impact from a societal perspective is actually quite significant. So in these models, we typically compare our model predictions to the data, and we have data about confirmed cases. We don't have data about actual cases because not every case is confirmed. And then there are methods in the literature for adjusting what we see in the data to estimate the actual number. So for example, the Centers for Disease Control and Prevention in the US has published some work about these adjustments. And they suggested that the actual cases could be 6 to 10 times the confirmed cases, particularly in the earlier parts of the pandemic. So we use all of that information in model validation. We also made projections about resource needs, particularly about hospital beds, ICU beds, and ventilators. These kinds of predictions help with planning. So for example, we identified some geographic regions as being at high risk for shortages in terms of these critical resources. And we came up with these pretty early in the pandemic, and unfortunately they what we observed or what we predicted came out to be true. But at least it was good to have some of these in place to give the decision makers heads up and help them prepare. So we have been contacted by several departments of education to help them assess the impact of school-related interventions. So we looked at a number of school reopening scenarios. So for example, what if we go back to normal and keep the schools open? What if we delay the opening by a certain number of weeks? What if we only send the younger children to school and the older ones do remote education? What if we implement an alternating day schedule where we split the children into separate cohorts, and maybe one cohort goes to school, let's say on Monday, Wednesday, and the other cohort goes on Tuesday and Thursday, so that the cohorts don't interact with each other. So we evaluated a lot of these different options regarding schools, and we show that this alternating day schedule, which actually splits the cohorts, the students into cohorts, can significantly reduce the infections, say, compared to opening the schools business as usual. And we also observed that delaying the school reopening would not have a big impact in reducing the number of infections, but buy us some time, just very similar to, say, shelter-in-place kind of interventions. So it may give us a little bit of time to put our prevention or other interventions in place, but really by themselves, they don't really do much good in reducing the number of infections. So from a societal perspective, we had a lot of discussions during the pandemic in terms of the impact of these interventions on the society and the economy. Yes, we do these things to reduce the infection spread, but what's the bigger impact? So that's a very complex question. I don't have the full answer for it, but to shed some light on this, we looked at a number of intervention strategies and looked at the trade-off between homebound person days versus infections prevented. So what do I mean by homebound? Somebody staying home because maybe they comply with an intervention such as shelter-in-place or voluntary quarantine, or they need to stay home to care for a child who is home due to school closure or remote learning, or they may stay home because of being ill with symptoms. So for a variety of reasons related to the disease, somebody might be homebound for a certain amount of time. And so one can envision that the more people are homebound, the bigger the impact on society and the economy. So we looked at a number of combinations of these interventions and found that voluntary quarantine combined with school closure actually gives the best balance in terms of keeping both the homebound days and the number of infections in check compared to some of the other interventions. Okay, so a little pause and transition here. So I talked about some of our COVID-related research using a detailed agent-based model. So as I explained earlier, these models enable us to capture lots of detail explicitly, directly, but they tend to be quite large. So for example, the population in Georgia is over 10 million, and in our agent-based model, we have about 1 million agents, which gives a good representation of the population. But the model is large and it's slow to run. So we have to run it on a parallel computing platform to get results in a reasonable amount of time. So to address the next couple of research questions, we developed simpler SEIR type models, extended SEIR type models. They give us a good idea about the disease dynamics at the population level. And some of these results and insights could be relevant for a variety of infectious diseases, and they run relatively quickly compared to the agent-based models. So one of the questions we asked is the potential benefit of serology testing in vaccine allocation, and here is the motivation, especially when we first started working on this. So the vaccine availability was limited, but there were already numerous people who have had COVID-19 and recovered. So presumably they have some level of immunity or protection against reinfection. Not necessarily at the same level as having a vaccine, but some level compared to a person who did not have COVID exposure at all. So this could be, these kinds of information can be important when we allocate a limited amount of vaccine or other resources to maybe focus on people who are most vulnerable at that point. So we developed some models to quantify the value of using serology testing to identify people who have recovered from COVID-19, and then maybe focus the initial allocation on people who are still susceptible. So the model, I'm not going to go into the detail, we don't have time, but in a nutshell, it captures different states. So for example, some people may have had COVID-19 with or without symptoms and tested positive, so we know their state status. And others may have had COVID-19 but not confirmed with a test. So unless we do a serology test, people who have been infected and recovered but not tested previously could receive the vaccine, even though from a societal perspective, when the vaccine supply is limited, it may be more beneficial to give this vaccine to someone who is still susceptible. So this would not only help the susceptible person who received the vaccine, but remember also it would reduce the chances of that person getting sick and then passing the disease to others. So we are kind of thinking more from a bigger perspective. So we found that this impact of serology testing in reducing infections or deaths is highest if vaccines are deployed at or around the peak, say within plus or minus 1 month of the peak. When we have these vaccines available too early or too late relative to the peak, then the reduction in the infection attack rate or deaths when using serology testing is marginal. So this is again to highlight that some of these interventions, the timing is very important to get the biggest bang for the buck for the intervention. If we do it too early or too late, we may spend a lot of time and effort and resources and not necessarily get a lot of benefit from them. We also developed some models to better understand the speed versus efficacy trade-off in vaccine distribution. So we explored how resources should be allocated between, say, a high efficacy vaccine that utilizes more resources per person. An example could be the Pfizer-BioNTech vaccine, which has high efficacy but requires ultra-cold storage, which may not be available in certain parts of the world, versus maybe a lower efficacy vaccine that's less resource intensive, say, could be stored at room temperature or maybe even given by a patch, maybe someday. So we showed that allocating our resources to the high efficacy vaccine, as you might imagine, does not always give the best results, and we can actually use these models to get an idea about how best to allocate these resources given some of the disease characteristics and the resources that we have available. So this particular study highlights the importance of considering a vaccine portfolio during vaccine development and also rollout, considering the resource availability in different regions. So historically, vaccine development focuses on two things. First, of course, it has to be safe. And second, efficacy needs to be high, but doesn't always consider some of these other factors, which are actually very important in deployment and the reach of the vaccine to a broader group of population. And I think I'm almost there. So briefly, we have developed some dashboards to help the public and the decision makers to make sense out of the data, because there is a lot of data out there, not easy even for people like us to make sense of it. So for example, one of these dashboards focuses on equity in allocation of resources such as vaccines. This is of course very important in public health. So this particular dashboard highlights vaccine administration by race and ethnicity in different counties within. and we update these over time, so it's possible to see the progression and inform the decisions as things change. So I'm going to conclude here. I invite you again to visit our center's website to check out some of our dashboards, to learn more about our modeling research. And I hope this talk provides a little glimpse into how modeling can play a significant role in public health in general, specifically preventing and combating infectious diseases, and hopefully inspires more research in these areas. Many thanks for your time and attention. I'm happy to take some questions if we have time.
Okay, thank you, Pinar. So let's first move to the questions that have been asked in the chat. I've seen the counter going up during the talk, so.
Okay, thank you. So we have actually one question, but it's not really a question. It's more like, well, it is a question, but not the typical kind of question, but I think it is of general interest, so I'm going to read it anyway.
Sure.
Klaus, we have a tracking system in the Johan Cruyff Arena, the largest stadium in the Netherlands. We collected pre-COVID data from walking patterns of 60,000 people during dance events and soccer matches. We will be publishing an article soon about contamination risks during these events. That will also be the last publication of this PhD student before he graduates. Do you see an opportunity to collaborate? Because we should do some further research with this very unique data.
That sounds fantastic. So yes, please reach out. I'm going to type my email address in chat here. So any of you who would like to follow up on any research, collaboration, please reach out to me. I would be very happy to discuss.
Okay, thank you.
Oh, that's great. Are there any questions here from the live audience?
Can you tell us a bit about the granularity of your agent-based models? I'm thinking especially of data that have nothing to do with COVID. Do you have a simulated population that uses public transport and that goes to work and that does other things in a more or less realistic way, completely independent of COVID?
Yeah, great question. A lot of data goes into the model. So some of it, like you said, is about the population and the population dynamics. For example, we have school groups in the model, and the size of these school groups depend on geographically where the population is. So each agent has a location, they are assigned to a family or household. Depending on the age, they're assigned to a school group or work group. And the sizes of these depend on the specific location, and the data we get is from census. So we try to capture as much as possible. For example, the school sizes and so on in rural areas might be different than what we see in the urban areas. The household sizes might depend, again, on the location. We have the data at the census tract level, and we incorporated basically by creating a population that's hopefully as realistic as possible, you know, given any modeling limitation. And some of the, say, transportation or other public space interactions are captured by the community. Community groups, again, this considers the geographic area. And then we also look at the, say, we have very detailed workflow data. We look at the cell phone data in terms of seeing who is moving from where to where during different times. And these changed quite a bit, by the way, as we observe the data, the mobility in terms of how people were moving geographically changed quite a bit. And the data also helps us estimate some of the compliance. For example, we had shelter in place where most people were supposed to stay home during shelter in place, but as you can imagine, not everybody did. So some of these compliance levels we can also infer from the data. And then a ton of parameters that come from other fields, medicine and biology and so on. But thank you, that's a great question.
Thank you. Are there any further questions? All the way in the back, let me run up.
Yeah, it's a bit of a follow-up question to this earlier question about the granularity of the agent-based model. I know that in the Netherlands, the Central Bureau of Statistics, they are really working on individual level networks of people at the individual level. So where they know per individual, what household do you belong to, what school do you go to, what level of what group of the school you're in, do your children go to the same school, this kind of stuff. And they are making these network files using those register information actually. So that's even more detailed than at the census tract as what you are mentioning. I believe that I just looked it up on my phone. It's like 4,000 people. Do you think that that incorporating such kind of detailed networks would be valuable to these models? And if so, would it be worth the effort?
Yeah, I mean, in general, the more data, the more detailed data, the better. How much it would impact the results and the value of the research, it really depends on the specific question that we are asking. So for example, say you have children with special needs and you would like to understand the impact on those children and maybe you want to capture them in more detail in the model. So I'm not sure, like in some cases it would be useful. For some of the questions that we asked, so for example, like when you look at the trade-off between efficacy and reach for the vaccine, you may not need that level of detail because the kinds of insights you would get would be more or less the same, whether you go with a very detailed model or with a simplified model. So I would say it's good to have the data so that you can use it in a much more detailed model if the research question calls for it.
Okay, thank you. Pinar, thanks a lot for your great talk, and I hope to see you soon in person.
Thank you so much. Thank you all. Greatly appreciated. Thank you.